Very good afternoon to one and all. At the very outset, I'd like to thank All India Ophthalmological Society, the Scientific Committee, and Dr. HIMADRI for giving me this opportunity. I'll be talking about endophthalmitis, medical management, and intravitreal injection, and I'll be just touching upon the surgical aspect as well. This is a picture we are all scared of after a very well done cataract surgery or intraocular surgery, but once we are faced with it, we have to know how to manage it. So what are the goals of treatment? It is to kill the invading organism, arrest the damage caused by endotoxins and exotoxins, and also arrest the host inflammatory response. What options do we have? We have to go for antibiotics in multiple routes, intraocular, intravitreal, topical. We have to go for a surgical intervention and use of corticosteroids. Now, what are the routes of intravitreal injection? Routes of administration of antibiotics. Intravitreal injection is the only surefire way to get the drug in the proper place, in the proper concentration. Topical drops and subconjunctival injection is not enough, and systemic medication can be given, as we'll discuss in the subsequent slides. So most of our idea about management of endophthalmitis comes from the results of the EVS or endophthalmitis vitrectomy study, which was published way back in 1995. But one important caveat is, in EVS study, only cases with clear cornea enough to perform a pars plana vitrectomy was included. That means all patients with large corneal infiltrates, very virulent organisms were excluded. So what were the conclusions of the EVS study? They said that there is no role of systemic antibiotic treatment. Routine pars plana vitrectomy immediately is not required when the visual acuity is better than PL. And pars plana vitrectomy is of substantial benefit only for those who have a visual acuity of PL only. Okay, so systemic management has systemic medications according to EVS has certain disadvantages. It prolongs the hospital stay, it increases the cost, and also has certain side effects. However, the ground reality is different, and most ophthalmologists feel more secure using systemic antibiotics. Also, systemic medications prolong the duration of the minimum inhibitory concentration, and we have a better chance of killing the all viable organisms. Now, in a landmark study published in Survey of Ophthalmology, they spoke about the new modified protocol for EVS. Here, after a diagnosis of endophthalmitis was made, it was recommended to immediately go for a vitreous tap along with injection of intravitreal antibiotics. The study also said that oral antibiotics had to be given. After the initial treatment, we have to wait for 24 hours for the initial assessment. And if there is a satisfactory response, we go ahead with the same treatment. However, in case of a poor response, there is no role of a repeat intravitreal injection. We have to go for a pars plana vitrectomy. These are the commonly used antibiotics for systemic medication. We prefer ciprofloxacin, 750 milligram to 12 hourly. These are the organisms which cause acute post-op endophthalmitis, that is coagulase negative staph, and propionibacterium acnes causes delayed post-op endoph. There are certain indicators which point us to a very virulent organism where we need to intervene aggressively. That is symptoms within 2 days of surgery, a vision of light perception, afferent pupillary defect, wound abnormalities, corneal infiltrate, and hypopyon greater than 1.5 millimeter. Coming to the choice of intravitreal antibiotics, the first choice is vancomycin, and if for that works very well for gram-positive organisms and for gram-negative. Although the first choice is ceftazidime, but if we are suspecting a very aggressive gram-negative organism, we can directly go for imipenem or piperacillin tazobactam combination. Most of the organisms are still, gram-positive organisms are still act with vancomycin, but for gram-negative, Ceftazidime, amikacin do not work that well, and we prefer piperacillin, tazobactam, or imipenem. So in the studies which have published to show the organism profile from all around the world, it has been noted that the organism profile in India is slightly different from what is seen in the West. Here we see a lot of gram-negative organisms, and among those gram-negative organisms, there is a high gram resistance against amikacin and ceftazidime. So in a suspected gram-negative organism, we should go directly with imipenem. Another entity which we should know about is endogenous fungal endophthalmitis, which resulted after severe COVID-19 disease. Why we should know about it is because it might present as a non-infectious uveitis, and treating it with only corticosteroids will lead to worse prognosis. Now, vitreous biopsy is recommended, and it is better than a tap because it avoids retinal traction and it avoids a negative tap. Alternatively, a AC tap can be used. Single port vitreous biopsy is a very simple and easy procedure, and all ophthalmologists should be able to perform it. It yields undiluted vitreous sample, especially when the visual acuity is better than PL and when PPV is not directly indicated and the organism profile is not very virulent. So these are the instruments which we'll need for vitreous tap. I'll be discussing the preparation of the individual drugs. Vancomycin we need in a concentration of 1 milligram in 0.1 ml. It comes in many forms, either a 500 milligram or a 250 milligram vial. For 500 milligram, we use 10 milliliter of sterile water for injection. This is mixed very well with the 500 milligram vancomycin vial. And one important thing to note is we have to keep changing the needles. We have to use a separate needle and 0.2 ml of the solution is withdrawn. This is because if we do not change the needle, some amount of drug stays in the hub and that can change the concentration. So again, using a new needle, we make it into 1 ml. It is mixed using various rotating motions, and we use a air bubble that goes up and down, and that helps in mixing it well. Again, the needle is changed to a 30 gauge needle, and we only keep 0.1 ml. It is labeled and capped to know what injection it is. Next, moving on to preparation of ceftazidime. We require a concentration of 2.25 milligram in 0.1 ml. It comes in various forms. I'll be discussing how to prepare from a 1 gram injection. 4.4 ml of sterile water for injection is mixed with 1 gram of ceftazidime. Again, we withdraw 0.1 ml of the solution using a new needle. The needle is changed. Sterile water is withdrawn to make it 1 ml. It is mixed using those rotating motions and allowing an air bubble to move up and down. Once we are convinced that it is mixed, we take a new needle and only keep 0.1 ml of the drug. Now moving on to the procedure. Endophthalmitis is a pretty painful condition, so we have to do it under peribulbar anesthesia. One thing to remember is that we should not press on the globe after the anesthesia, because these are post-op cases and there is a chance of a wound leak if we go for a massage. Dressing and draping is done in the usual fashion using povidone iodine. I'll now be showing how to prepare the vitrector. Almost all phaco machines come with a vitrector, and we can use this vitrector for performing the vitreous tap, vitreous biopsy. The irrigation and aspiration lines are connected as directed in the machine. The infusion line, although connected, will not be used. The machine is primed in the usual fashion. We need this yellow adapter which comes with any IV cannula system. This is required for aspirating. It is connected to the aspiration line and will ask our assistant to withdraw. The irrigation is kept aside. Now coming back to the eye, you can use this trocar cannula system to measure 3.5 millimeter from the limbus. If you do not have access to a trocar cannula system, you can use a MVR blade. We make an entry into the globe and we have to first inspect whether the cutter is working or not prior to entering the vitreous cavity. After we enter the vitreous cavity, we start the cutting. Once we have done a little bit of a cutting, we ask our assistant to withdraw using the syringe. So this way we avoid all vitreous traction, and we do not need too much of a sample. Only 0.5 ml sample is adequate, and we should stop the moment we observe any amount of hypotony in the globe. This sample is kept aside and has to be sent for microbiological evaluation very quickly. We put a needle and we have to bend the needle. Next, we go ahead with the intravitreal injections. We are using separate syringes for the injection because otherwise they form a coagulum if injected together. Injection has to be done slowly, drop by drop, into the vitreous cavity. Once the injections are done, we remove the cannula, and we should not hesitate to put a suture if we notice any amount of wound leakage. Always attempt to keep the globe slightly on the softer side. So with a vitreous tap, even very aggressive cases can work very well. Now, there are certain indications where we go directly for pars plana vitrectomy. These are cases where the organism is very highly virulent. Patient has a visual acuity of PL only, no response to the initial treatment with intravitreal injection. In post-traumatic cases and in fungal end-off cases, we directly go for a pars plana vitrectomy. So in pars plana vitrectomy, we use the usual 23 gauge or 25 gauge systems. It's very important to visualize the infusion cannula. If we need, we can clean up the anterior chamber a little bit if the visualization is not easy. We do not try to induce any PVD in most of the cases. In most cases, simple core vitrectomy is enough. We do not attempt to go to the periphery. We'll just be doing the core vitrectomy till we can visualize the optic disc and the macula. Once that is done, we tend to stop and go for the intravitreal injections. The infusion cannula and the other cannulas are removed. And at the end of the surgery, if we have any doubt, we can always put a suture. So this was a case of post-traumatic endophthalmitis, and even post-traumatic endoff can have good results. This is a e-kit which comes from Oro. Again, no financial interest. But this kit has all the necessary things for an intravitreal injection, and every anterior segment surgeon should at least have one of these in their armamentarium. Coming to the role of steroids, steroids definitely have a good role in bacterial endophthalmitis. However, we do not use them in cases of suspected fungal endoff. These are the microbiological workup necessary. In delayed post-op endophthalmitis, we have to go for a pars plana vitrectomy along with a capsulectomy because with only injections, they have an unacceptable high rate of recurrence. So to summarize, early diagnosis and management can save most eyes. Intravitreal vancomycin is good for gram-positive organisms. In suspected gram-negative, we have to go for imipenem. And vitreous biopsy using a single port for microbiological workup should be done in all cases of suspected endophthalmitis. And in patients who fail to respond to initial treatment, a vitrectomy is a must. Thank you very much.
Thank you, Dr. Himadri. If we have any questions from the house, we'll be more happy to take it. One important point for those who came late about the pre-operative preparation, a drop of 5% povidone iodine in the conjunctival sac and a contact time of 3 minutes is very, very useful for prevention of post-operative infections. It is a must and it should be done. And painting with 10% povidone iodine, and in the conjunctival sac 5% povidone iodine. That is the concentration that is